Hello and welcome everyone to this first of 5 webinars in a series focusing on racial inequality in maternity healthcare. These sessions are scheduled over the next 2 months. The full schedule of the events can be found on our website, and a link will be sent to all attendees after the session. Please do feel free to share this link with anyone you think might be interested. My name is Olivia Boschat, and I'm an associate solicitor at Bolt Burden Kemp Solicitors. I will be hosting some of these webinars. Firstly, it's really nice to see such a diverse range of attendees today, including clinicians, midwives, students, doulas, and charities. Very warm welcome to you all. I'm delighted to welcome the speakers for today's event, Wendy, Olayiwola, and Kate Brintworth. Kate is the Regional Chief Midwife for London. She has worked strategically across many parts of the maternity system, has been part of the regional maternity networks, national expert reference groups for commissioning, postnatal and continuity of care, and research steering groups for complex programs of research. Kate is a very experienced midwife and has worked in many different positions, including labour ward coordinator, risk manager, matron, and has been involved in many investigations. Kate has a specialist interest in system workings, organisation of services to support midwives and women, equality in service provision, and women making complex care choices. Welcome, Kate. Wendy is the National Maternity Lead for Equality, NHS England and NHS Improvement, and a professional midwifery advocate in a large NHS trust. She is a registered nurse and midwife with more than 2 decades of experience in community and public health. She is a member of Nursing and Midwifery Council, Equality, Diversity and Inclusion Research Group, and the lead midwife of the Strategic Advisory Group, NHS England. She also leads and is heavily involved in a number of organisations for better health in Africa and around the world. Thank you for joining us, Wendy. We are very grateful to both Wendy and Kate and fortunate to have them speaking today. In today's webinar, Wendy will be speaking first about cultural intelligence, and then Kate will be discussing anti-racism frameworks within the maternity services. After the talks, there will be a question and answer session. If you have any questions, please put them in the Q&A box at the bottom of your screen, and we will answer as many as we can at the end. These webinars are being recorded, and a copy of the recording will be sent out to all attendees following the session. Please do feel free to share with anyone you think might be interested. Without further ado then, I'd like to hand over to Wendy to begin her talk. Thank you, Wendy.
Thank you very much, Olivia. I hope you can hear me okay.
Yes, I can.
Fantastic. Thank you very much. Such an honor to be on this platform this afternoon, and a privilege as well to share this conversation with the participants. So my name is Wendy Olayiwola, as Olivia has already introduced me, and we shall be having this conversation together. So please feel free to put your comments in the chat. So today, across maternity and wherever you're from or what specialist you are at, I want you to think outside the box this morning, or this afternoon, actually, it's past midday, is how do we promote cultural safety and cultural intelligence within the maternity services? And what does culture really mean to you as an individual and as a professional? So it's also important that we actually, remind ourselves what the NHS, when NHS was founded and what it was founded upon. So as we all know, it's just a reminder, this slide actually, as we all know that NHS was founded in 1948. In 1948 as an instrument of social justice with the understanding, that everyone should have equal access to health outcomes, irrespective of the ethnicity, of their backgrounds, of their sexual orientation, of their race, disability, or gender. So this is how we started the race. This is how we started our NHS. It is free for all and it is for all, regardless of everyone's background. So within the maternity system, we do all know the challenges that we have been facing for the past few years or even going to decades now. So why is it important for us to work to improve equity and equality within the maternity system? We know that equity is a key component of high quality care, and it will also help us to achieve, the half aim, by the government, and it is also a legal duty as well. Like I said, the NHS was founded on a common set of principles and values that bind together the communities and the people it serves. So in terms of the legal duties, we have our NHS Constitution, we have our Equalities Act 2010, which says that when making decisions of a strategic nature about how to exercise its functions, have due regard to the desirability of exercising them in a way that is designed to reduce the inequalities of outcome which result from socio-economical disadvantage. And we also have Health and Social Care Act 2012. And not forgetting, there are other things that we also have that helps us to think along the side. We have the WHO standards for improving quality of maternal and newborn care in health facilities. And this is a document that actually, outlines what a global maternal health, care should look like. And we also have, the midwifery and human rights, a practitioner guide that helps our, our midwifery colleagues how to look at things and how to act, and also to help them in provision of care. And the human rights, like I've already mentioned, and recently the Care Quality Commission recently published a safety, equity and engagement in maternity services. Again, I shall be touching on that in one of my slides, and it gives us a bit of view as to how the maternity care should be provided. So I'm sure many of you have seen these lovely favorite slides over the months. And this is equity. What does equity and equality mean to us? So when we provide universal service such as maternity care, we need to make sure that the care reflects a person's particular circumstances. So we know that equity is safe and is personalized care for all. So if a community would benefit from more help to achieve the best outcomes, then they should receive that help. So this is known as proportionate universalism. So proportionate universalism is described by Sir Michael Marmot, in his Fair Society, Healthy Lives report, which was published in 2010 and 2020. And this framework underpins our work to achieve equity, and also healthcare has an important role, but not the only role. So there are other factors that is associated to this. So the social determinants of health are really important. The NHS cannot do this on its own, so it has to be, a joint effort. I'm sorry, I didn't realize. I'm not sure if you saw that slide of equity and equality, which is the service, level is the same for all as the equality one, and the equity is the clinical outcomes as good as for the groups with the best outcomes. So approaching, our approach to achieve equity, again, we know, like I said in my last slides, that Michael Marmot's review proposes a strategy to address social determinants of health through 6 policy objectives, and the highest priority objective being giving every child the best start in life. So the picture in the last slide, that if you need more help to achieve this, then you should get it. It illustrates the concept of proportionate and universalism. So this is to improve the health for all of us and to reduce unfair and unjust inequalities in health. So action is needed across the social gradient, but with the scale and intensity that is proportionate to the level of disadvantage. Therefore, it is an approach we are all very familiar with in education. There is a universal schools offers for children with more intense support for children with behavioral, social, or physical needs. Therefore, if that is required within the maternity system, then we should provide it. Not forgetting, again, this slide is just to remind us about COVID-19 and the pandemic where we are still very much in the pandemic. So during the first wave, the UK study, the UK obstetric surveillance study actually looked into people that especially pregnant women that died during the first wave. And out of those pregnant women that 55% of pregnant women that were admitted to hospitals with COVID were from ethnic minority backgrounds. And this is not explained by higher incidence in the big cities. And also, for out of 8 women that died, during the first wave of the pandemic, 7 of them were from ethnic minorities. And what COVID-19 has really done was just to shine the light on the inequalities that's already in existence. So briefly, and I'm sure again, not assuming that everyone has seen this slide or the recent report of the Health Embrace report that was recently published about a couple of months ago. Again, things have not changed. It is the 8th Embrace report, a different year with the same report, the same result. So we haven't really moved much. We still have, our Asian and mixed ethnicity women twice more likely to die in childbirth, and Black women 4 times more likely to die in childbirth. So it is important, that we carry these statistics with us. We embrace these statistics so for us to be able to make the necessary change. But again, I think for many of us, we are very confident that things will start changing, and we are very hopeful that a lot of interventions that is being placed both at national level and regional level will start changing the narratives and providing the equity, and equality care that many of our communities do deserve. So it's a good news. Perinatal mortality rate is falling, over many years. Between 2013 and 19, we have saved just less than 3,000 babies. And that's such a good news. And thank you to all the midwives, obstetricians, the pediatricians, all the maternity workforce that have really invested the time, the energy, the resources, the skills and knowledge into ensuring that, our mother and babies are receiving, a safe care. However, is this the story for all communities? No. We still have ethnic minority babies, not actually, having the same care as our white communities. So again, the Embrace report that came again few months ago, I refer to that report because it's a combination of the impact of ethnicity, deprivation, and maternity age. So if you're from ethnic background and you live in deprived areas and you're younger or older, again, the impact is much more higher. Therefore, I refer to that report as triple whammy for Black and Asian women and babies. So despite that the perinatal mortality is falling, but it's not falling and it's not reducing for some communities, for ethnic minority communities. So for these communities, the Black and Asian babies are still 4 times more higher of risk of stillbirth and twice more higher of risk of neonatal mortality rate. Again, this is just this slide, it's a slide or it's a report of birth and infant mortality by ethnicity in England and Wales. And this is the very first time such a report will come through. And again, it hasn't showed anything different from what we did not know. So the main part from the ONS report that was released in May of 2021, the insight that it gave to us was to tell us about the cause of death for ethnic minority babies. So we do know that the cause of death for Black babies are very much around preterm labor or preterm birth. And also for our Asian babies, is congenital abnormalities, especially for Bangladeshi and Pakistani ethnic groups. So these are very much the cause of death for babies. And again, there are a lot of interventions which I will be sharing with you that is being put in place to address these issues. So what do we know? What do we know about our ethnic minorities? What are the researches? What are they telling us? what are the intelligence that we have currently, and are these true intelligence that we have about our ethnic minorities. And when I say ethnic minorities, I'm referring to the Black, Asians, and mixed ethnic groups. So we do know from the research that was done a couple of years ago of 26,000 women, the feedback that were received where ethnic minority women were less likely than white British women to access care within 12 weeks of pregnancy, access services late. And is that the true story? Is that why are we already, labeling them that they are not accessing our services early? Could there be something relating to culture? So we really need, couple of my slides, we actually highlight that towards the end of this presentation. So I just want you to be holding some thought in terms of what we know and what the reality is in those different communities. So they were less likely to have a scan at 20 weeks. Is there a reason for it? Ethnic minority mothers were more likely to experience complications during pregnancy and birth. Again, the recent publication by Embrace report, as well as deep dive that they did, will also give us some answers to this, why these are. Black and Asian mothers are more likely to have an unplanned cesarean section, meaning emergency cesarean section, and having the baby cared for in a neonatal unit. Again, why is this so? They were less likely to attend NHS antenatal classes. Again, is it a cultural thing about that? I've already done a deep dive why they don't attend antenatal classes. What are the other options? What are the cultural options that they want to explore that we are not engaging them with? And having a postnatal checkup, again, that's what the survey, confirmed, but is that the true version of these communities? Some communities don't come out after 40 days when they give birth. Do we actually have that intelligence? So I have a couple of case studies to share with you, and this case studies was taken from the most recent publication of deep dive into women that died in childbirth in the UK. So the first one, and I've really highlighted a couple of things that I want you to ponder on today. So lack of individualized care. An Asian woman with difficult social circumstances and significant medical comorbidity presented to the emergency department in the postnatal period with severe vomiting. Despite a significant metabolic imbalance, she was discharged home with oral antiemetics. So because of time, I'm going to jump, this slide, and this influenced the decision-making of ED. They just, she went home, with antiemetics, potassium supplement. This is a woman that was actually meant to be admitted in the hospital. She's a postnatal and just, had a baby, but she went home, she collapsed and died a few hours later due to a cardiac arrhythmia in relation to the metabolic disturbance. So again, what they felt and what they saw after looking into this case was because of the woman's ethnicity meant that the extent of her social difficulties were underestimated. This influenced the decision-making of the emergency department team, and hence she was not admitted. This was a vulnerable woman for whom she was an even greater need for care, and the threshold for admission should have been lowered. So the second case study is about complexity. Again, how much do we know our women that come from different backgrounds to us? A woman in her 40s from South Africa, a long-time UK resident, meaning she understood the culture of this country, had a complex lung condition which had necessitated a recent admission to intensive care. She was under the care of respiratory cardiothoracic specialist, but did not receive any pregnancy counseling or contraceptive advice and had an unplanned pregnancy. So this woman had many complexity. She saw many multidisciplinary teams, but the sad thing about this case, none of them were communicating with each other. Nobody knew per se what the other, professional in our care is doing. So she had multiple professionals involved in her care, all saw her independently, and there was no multidisciplinary team assessment until she deteriorated acutely when her care was transferred to another hospital. The maternity in that hospital was not even aware that she was in the hospital. So no evidence of a documented discussion around planning mode of birth. Again, if you take your mind back to my previous slides about why women are having ethnic minority women are having more emergency cesarean section, this is one of it. Her condition continued to deteriorate, and despite an expedited preterm cesarean, session, she died. She had emergency cesarean section, and she died. So, what were the issues that identified from different groups? Many literatures have confirmed this. Women themselves have spoken about them. For Black women and Asian women. For Black women, it's very much around implicit and explicit bias impacting on the care that they received. Women have said eloquently, clearly, that they're not being listened to despite repeat presentations to our maternity services. Black British women said, no, again, this is an assumption and is a perception of Black women have a low pain threshold. And we had a couple of examples that they are not even being given the correct and right pain relief. The pain relief are not being, appropriately managed. Hence, they still see Black women having low pain threshold. Lack of awareness and understanding of the importance of women's background actually came through clearly across many literatures and across verbal conversations that we had with women. So for example, one woman was described variously as Caribbean, the same woman, Caribbean, again, Sierra Leone, or even Jamaica. So this shows the lack of understanding of different ethnic groups that we look after. It also showed the lack of understanding, of where people come from, their nationality, their ethnic groups, and these are the people we provide care for. And how do you provide adequate, safe care for someone that you don't know? And if a woman could be referred to as someone coming from a Caribbean is a Caribbean. And Sierra Leone is from Africa. Those are two different places. And the Caribbean is also different from Jamaica. So again, intelligence, emotional intelligence, cultural intelligence of the women or community that we look after. Now, going to the Asian women, they suffered a lot from microaggressions. And even though across the ethnic group, literatures and research and feedbacks did say that microaggression is very high, particularly among Asian women, downgrading or dismissal of symptoms. One of the examples that I can give was an agitation in women who did not speak English, but was attributed to mental health problems when women were severely physical unwell. Again, ignoring the right signs for the right women. I'm going to skip these slides and just go swiftly because of time. The national actions, there are a lot of national interventions to improve equity for mothers and babies from ethnic minority, being specific Black, Asian, and mixed ethnic groups. It is important, we have seven regional chief midwives, the deputy, the obstetric leads by each region, working together to address these issues. And we're very, very lucky to actually have this group of people in position to work closely with providers and the local maternity system to address inequalities within our regions. And obviously we are also using regional approach as well, because different regions have different challenges. Not going to go deeper into continuity of care because it's something that we know and we all believe in, and we know that it works and it saves lives and it provides that individualized and personalized care. And we've had testimony of women that have been on this model, how they feel safe, they feel heard, and they feel it is the right thing to do for all women. And we do know that by 2024, according to the long-term plan, that 75% of Black and Asian women would have been put on this model. So not forgetting about the recent equity and the NHSE and I equity and equality guidance for local maternity system, which was published in September. Again, this is a game changer, in this space to support and help start changing the narratives, start changing that embrace report, working with the system, engaging with the system as well as the community, to address these issues together. So moving swiftly to how do we develop a culture of equity, equality, and inclusion for our maternity staff as well, that we have impact on the care that we provide for those community. So one is to create a culture of fairness and inclusion, because our staff actually reflect our communities, and those communities come through into our workforce. So it is important not to forget about that they are both interwoven. So the CQC Freda principles of fairness, respect, equality, dignity, and most especially autonomy is very key. So respecting diversity, promoting equality, and ensuring human rights, we have to ensure that everyone using our maternity services receives safe and good quality care. So again, just to quickly put it in there, just and learning culture, we need to have a culture, that our midwives, our obstetricians, our maternity workforce can also learn from. So if there is a mistake that happened, they can learn from it. Because of time, I'm going to jump into the appropriate diversity and inclusion training for staff. Yes, I'm sure a lot of hospitals and providers are already doing that. But what is the real sense of having a right training for staff? And we all know that the cultural competency and safety e-learning tool training, it's something that has really worked very well over many years. And I'm so really glad to say that e-learning training tool, is being updated as we speak by NHSE and Health Education England to actually roll out across the country to support our staff. So that training is coming as 3 modules, the first 2 modules as a general module, and the last module being specific, on maternity. And it's going to add value to our equity and equality guidance. So what is important of cultural intelligence? Now, we do know about unconscious and conscious bias, and we all have it. It is good to be aware of our unconscious and conscious biases. We've had, we all have a degree of it, as I always say, and we should not deceive ourselves. We are not going to eliminate it. It does not matter your culture, your gender, we all have it, and we all, obviously express it or experience it at some time. But over the past year, we have spoken about it so much that those conversations themselves should hopefully have gotten people examining how they relate to others, especially as professionals. So we are meant to give good quality and safe care regardless of the person's color, grade, religion, or sexual orientation. This is why one of the areas we want our maternity workforce, especially midwives and service providers, to focus is delivering culturally sensitive and safe care, and one that meets individual needs to the women. So moving away from unconscious and bias training, is taking cultural competency and safety training that I've already mentioned to the next level. So what does that mean in terms of what that next level is? It's cultural intelligence. Cultural intelligence, refers to the skill to relate and work effectively in culturally diverse situations. It is the capability to cross boundaries and prosper in multiple cultures. It goes beyond our existing knowledge of cultural sensitivity and awareness by highlighting certain skill sets or capabilities needed to successfully realize our objectives in culturally diverse situations. An individual possessing cultural intelligence is not just aware of different cultures, but they are able to culturally adapt, and effectively work and relate with people across a variety of cultural contexts. Cultural intelligence, links to emotional intelligence, but goes a bit further. So people with high emotional intelligence can pick up on the emotions, the wants and needs of mothers and their families. People with high cultural intelligence are attuned to the values, beliefs, and styles of communication of people from different cultures. They use this knowledge to help them relate to others with empathy and understanding. So one of the benefits of having a well-diverse workforce and also having a workforce that reflects the community we care for is that the staff from that community gives intelligence about culture. They give value beliefs, they give the values, they give the beliefs, and also the communication style of that community. So moving swiftly because of time. So when we increase our cultural intelligence, we begin to identify our biases, and it helps us to address it appropriately. So it is important that this is done. So what is the call to heart this afternoon for everyone? Respectful maternity care. So what does that look like? A culture of respectful maternity care, listening to women. So in order for us to address cultural racism, its role as a contributing factor in the high rate of maternal death of ethnic minority, of maternal death of Black, Asian, and mixed ethnicity, and also those living in the most deprived areas, not forgetting them. It is very meaningful, it's a meaningful change to occur. The providers, the clinicians, we really need to understand the impact of racism and bias on our maternity services. So a culture of respectful maternity care is a culture that listens to women, regardless of what they look like or regardless of what their backgrounds are, provision of culturally sensitive, safe, and quality care. It is an evidence-based care. When you respect someone, you listen to them. When you listen to them, when you respect them, you action promptly as professionals. It's a woman-centered care, and it's a personalized care for women. Women are in control of their care, and we are just there to support and provide. They lead the way. We provide that care with empathy. We communicate. Respectful maternity care is good on communication. Language is key. It is important. The way we communicate with women or birthing people or the families and communities are key in this space to address those inequalities and to address those, the inequalities, as well as to make it an equitable care for them. So we should have a standard framework for translation for women, though that the first language is not English. I think this is very key, that where every woman can feel safe and feel heard when they come into our maternity services. Confidence and knowledge. Staff should know the role and challenge. As midwives, as obstetricians, or those that are working within the maternity, we should advocate for change in improving education, clinical training, and all maternity services and settings to achieve non-discriminatory quality and safe care for all women and their families. As clinicians, we need to challenge ourselves, our colleagues, and our leaders to promote clear actions with accountability measures. This is very key. So finally, we don't need to look for the answer anymore. Let's be the answer. You and I can be the answer. Looking for the answer is passing the ball. Let's be the answer. Let's change the narrative. Let every woman feel safe, as the vision of the Chief Midwifery Officer is to have a country, England, that everyone can birth and feel safe. So don't be a standby. Don't be standby. Be the people who improve maternity care for all. Thank you.
Thank you so much, Wendy. That was really excellent. I think we'll pass straight over to Kate now, and then we'll come back to questions at the end, if that's all right. So, Kate, if you're happy to share your screen. Thank you.
Thank you very much, Olivia, and thank you to Wendy for, as ever, her excellent presentation. Excuse me a minute while I just try and share my screen. I'm not so familiar with Zoom, so do bear with me if this doesn't quite come off. Olivia, can you just confirm when it all looks like it's doing the things it ought to?
I can see it now.
Great, thank you very much. So as I've said, thank you to Wendy for a really excellent presentation, and I think really helpful to hone in on those core principles of what makes the NHS so special and important to us all about equity. But it's not just about equity for those for whom we care, although is absolutely 100% upfront and important, we also need to think about staff. And I'd like to talk today a little bit about some of the work that we've been doing in London. So London, as a region, has 18 NHS trusts providing maternity care over 26 acute sites. So that's a site that has an obstetric labour ward and an alongside birth centre. And we also have 3 freestanding midwifery-led units. And we are unique in that we also have 1 private maternity hospital. The thing that characterises London, though, and one of the things that I love most about it, is its diversity. We're often quoted as being the 2nd most diverse capital in the world, second only to New York. And I think it's one of the great strengths that we have as a region. But we also need to think about what that means around our staff. So as Wendy mentioned, we need to think about who's looking after the women that we care for. Are we offering the same diversity back? So as Regional Chief Midwife for London, this is definitely in my portfolio of things that I need to think about and I need to do. So ostensibly my role is about the safety and quality assurance of services in London. It's to offer leadership to those services and also to be very acutely aware of the perceptions of midwifery, what is happening in midwifery and how can we ensure that we are succession planning for our next generation of midwives. But actually what it comes down to is everything perinatal. So perinatal is the term to refer to the period across pregnancy, birth and in the immediate postnatal recovery. So this for me is a really important focus of my work. So Wendy has covered some of this around the inequalities and inequities that we see. And I think it's really, really sobering to think that the colour of your skin, your ethnic background can influence what happens to you. But this is the reality that we're facing. This isn't new, though. This has been going on for years. And I think what COVID has done is it really brought it to the fore, which is, I'm a glass half full person. So I always try to look for the things that are good out of what we have experienced. And for me, this has been a really, really important, good thing that it has absolutely pushed to the front this long-standing problem around biases for both our staff and the women for which we care. And we really need to open our minds to what might be contributing to this. And what I'd like to talk about is a focus on the staff by looking at some of the statistics of the challenges that staff have faced and some of the work we've done around culture of kindness, our fellowship programme and our anti-racism framework and what's generally happening across the NHS in a broader sense. So Robert Francis Coetzee wrote a report called Freedom to Speak Up, and in it he talked about some general experiences that the term BME was used in this report, staff from ethnic minorities were experiencing. And what he found in that report is that if there was an investigation, staff from ethnic minorities were less satisfied with the outcome. They didn't feel they'd have been heard. They didn't feel they'd had a voice. They were more likely to feel that they'd been victimised, significantly more likely to feel they were victimised, nearly twice as likely, less likely to be praised if they raised a concern, whereas white staff were told, oh, well done, yeah, that's a great thing. They were undermined and made to feel that they hadn't done the right thing. And also, unsurprisingly, as a result, were more likely to feel that it wasn't worth raising a concern because things weren't going to go well for them. And the report that you see on the right-hand side of this slide, Turning the Tide, is a report that was written by Dr. Gloria Rowland and a team of midwives who self-organised during the pandemic to listen to over 1,000 voices of maternity staff across the country. It started off in London, but spread across the country to say, what's it like for you? What are the things that have been issues for you? And really was a sense of those staff saying, anecdotally, we're hearing that things are bad, but we really need to see this. We really need to hear and listen properly to what staff from ethnic minorities are telling us about their experiences. And actually, it was hard during the pandemic. It was really, really hard. Midwives were wrestling with, do we allow visitors into units? We had you know, is that, bring more people into the unit? Are we going to increase the risk of infection for people who are inpatient here? Staff who were vulnerable themselves who had their own illnesses, their own concerns. There was a great sense of loss. For so many people, we had, as often is talked about, the loss of our freedoms, but people were losing family, they were losing friends. Where there were concerns about things like water birth. Is that safe? What do we do with the students? What about going into people's homes? What if it's full of COVID and I don't know and they don't tell me and then I go and pass it on to someone else? So the concerns about PPE, concerns about people were working really, really long hours. You hear in the news all the time, staff are exhausted, staff are exhausted. It's because they didn't stop working throughout the pandemic. In maternity, we're a service that doesn't stop. You hear a lot in the NHS about waiting lists and, oh, you know, there's 5 million people waiting. You don't wait in maternity. It's one of our defining features. So there was a lot for staff to grapple with, a lot for staff to worry about, feel concerned about, as well as obviously caring for those that they looked after. So as I said, we have a slew of reports, really, I think is the only way to describe it, that talk about the issues that we have had, that our staff from ethnic minorities have seen. So there was a report listening to London's midwives by Capital Midwife, which is a programme that I'm involved with at NHS England that is there to try and help and support London's midwives. The Royal College of Midwives did a very, very important piece of work that looked into the experiences of ethnic minority midwives in relation to disciplinary proceedings and found incredible disparities in terms of who was being disciplined and the number of midwives sacked. And that showed that of approximately, excuse me if I don't have the numbers absolutely to my fingertips, around about 35, 36 midwives who were sacked over a number of years in London. Something like 34 of them were from an ethnic minority background. I mean, that is absolutely shocking. It's a terrifying statistic, and it's something that as a leader in maternity, I cannot ignore. I have to say, what can we do about it? How can we help? There are a number of reports that NHS England have published, which talks about a fair experience for all, trying to close some of those disparities that we have seen. A model employer, which talks about increasing leadership. So work is out there to say there are things you can do to change. But one of the things that midwives talked a lot about was a culture of kindness, was how people responded to them, how people spoke to them on a day-to-day basis. So some of the work we did was to have some webinars for midwives that just were talking to people about basic civility. What are the things that we could do? And that was pulled together into a toolkit that we have published and have been promoting throughout London's services. And some of the things in there were encouraging wobbling, so creating safe spaces for this exhausted group of staff who were facing all these concerns, but also things like having a first name approach where everybody has one name, so we take away some of the hierarchy that we know can at times be quite damaging in terms of multidisciplinary team working, but also implementing a real name approach. So we know that often colleagues who have names that somehow don't seem to be typical to people, they get changed. And Thandi Newman was the person who came out and talked about this, and talked about how she had changed the name that she was born with to a name that was more acceptable. So there was hello, my real name is implemented. So just small ideas, but really important ones to make people feel welcome and included and engaged. But we really needed to go further. So this was about how everyone might be behaving towards one another at work. But we had the Turning the Tide report, which I've already referenced. We had London had produced a workforce race equality standard. We had the Association of South Asian Midwives, and who had produced a report saying what we need to thrive. And the Society of Afro-Caribbean Midwives had also been part of that, talking again about the experiences of maternity staff, saying this is what needs to happen to make our lives better. And we brought all this together and formed a Capital Midwife Equality, Diversity and Inclusion group with links to the Royal College of Obstetricians Race Equality Task Force to say, well, what can we do? How can we pull all these recommendations, all the things that these reports are saying to us that we need to do and make important? What active contribution can we make other than just writing another report saying things are really difficult? And that was definitely the drive, that we wanted to do things that were concrete to help. And one of the things that we've found is that actually a lot of maternity leaders have said, I know this is a problem, I know this is difficult, but I'm not actually sure what I can do in maternity. So we instigated 2 items that we wanted to improve change. So the first thing was we pulled together a fellowship programme. And this is aimed at ethnic minority midwives who have felt like they're stuck, that they aren't making progress in their career, that they can't make the change that they want to see, or they are being blocked from making the change that they want to see in their career. So we wanted to support them to have a sponsored fellowship programme where they get leadership initiatives, where they get training from organisations like RADA, and we also help them with navigating the world of jobs and gaining promotion and opportunities. What was interesting about this was the challenge that was put to me around this came from the recommendations from both the Association of South Asian Midwives and Society of Afro-Caribbean Midwives and the Turning the Tide report. This was very much what midwives were asking for. They were saying, we want this kind of support, we want help to navigate. But a very brilliant woman called Janine LaRose has said to me, but that's very much a deficit model, isn't it? It's about saying the people who are experiencing the discrimination are the ones that need to up their game. What are you doing to support those who are in positions of power to change what they're doing? And that is where our anti-racism framework was born, which took not just the recommendations that midwives from ethnic minorities had made to us, but took a broader view around what they were saying, but also what we were seeing across the NHS, and said, let's put together all these initiatives, all this work, and create a framework to say, this is what good looks like if you are really working to support your staff in maternity. Oh, sorry, struggling with my mouse there. So the framework initiatives, there are 9 of them. There could have been 90, but we decided to hone in. We had a fantastic EDI group who had representatives from education, we had medics, people with lived experience. So many people came together from different organisations, Royal College Midwives, Royal College of Nursing, all sorts of people came in to say, this is what we think you should do. And those discussions were so rich and so important. And this helped us whittle down the sadly incredibly long list down to these 9 focus areas. So it's about ensuring midwives are in leadership and advisory roles, but also understanding local needs. So get a team, get a group together, start having a group that will allow you to properly listen to people and let everyone be part of the solutions. Having an equality, diversity and inclusion statement, but not just having a statement that you've worked to, committed to, and then are going to work through to make sure you deliver it. Making sure that career progression opportunities and continuing professional development opportunities are available to all staff, but especially ethnic minority midwives who traditionally do not get access to those opportunities. Having a programme of learning activities to grow cultural competence, which Wendy has already talked about. Debiasing people management processes. What are you doing about your disciplinary process? Do you know who you've disciplined? Do you know the profile of those staff? Have you stopped to think about what's happening? Encouraging speaking up, making sure that your processes within your unit make safe spaces appear. And as I've said, developing and promoting forums and debiasing recruitment. Again, a lofty set of initiatives, again, which are principles, but what we wanted to do was just to go into those in some detail, and we have created products and programs and programs of work that people can work through so they can implement those things. So we've had information sessions, we've created resources, and we've got a plan. So the framework works in that you will start at bronze to working towards bronze level, working through silver, gold and platinum, gradually getting further and further into this work, so you really dig it into the work of the unit that you're working in. Finally, just to mention that within the NHS as a whole, equity and equality guidance for local maternity systems was published in September of last year, which is asking that all areas of the NHS who deliver maternity services do a review of those that they look after, their staff, and work out a plan for how they can improve equity and equality. So the work that we had already developed in Capital Midwife very much is a complement to the broader work within the NHS to try and improve what happens. And this for us is really, really important work. As I said at the beginning of this presentation, we are lucky to have such diversity in London, but that diversity means we have to make sure that it feels a diverse and happy place for everyone that works here. And finally, I'd like to finish with a quote from Maya Angelou, which is very well known. You see it all the time, but I think it's such an important thing to say. How do you make people feel every day when you go to work? And that is what we at Capital Midwife were really interested in changing. Thank you.
Thank you so much, Kate. That was really, really interesting, and may I say, really quite easy to follow. So I'm really grateful to you. We have got a few questions. I'm conscious of the time, but we had one question through from Helen to say, I think this was directed to Wendy. You mentioned about the training modules for staff. When will these be published for staff to use, if we know?
Yes, we do. We are hoping it would be launched April, May. So the information will be shared across.
Fantastic. Sort of as a follow-on almost, I guess, I suppose, in relation to modules and training, we have another question about training for healthcare students, particularly nursing, midwifery, medical students, and the level of unconscious bias or bias training at all throughout their degrees. I don't know if you know what the current training is, and is that adequate at the moment? Are you happy with that?
Shall I start by coming in there? I think it's one of the things that our EDI group picked up on. They were really keen to tackle this. But because we couldn't do everything all at once, we've started with the fellowship and the framework. And once the framework's up and running, we want to work very closely with our education providers. I think it's something from the feedback and the discussions we've had with them that they are very aware of and are aware that there is a deficit and are starting to work towards change. But I think what we'd like to make sure is that there is some kind of minimum that we are achieving in London, ideally the maximum. Of course, you always want to aim for the maximum, but I think that's definitely a programme of work that we want to get into. But very much a lot of awareness about this, that education providers are aware there's a gap that they need to work on. And interestingly, Turning the Tide talked quite a lot about this, about not just about if you like, equipping staff for how they go out and work with women, but there's also something about decolonisation of the syllabus. So the word just completely eluded me there. Curriculum, thank you, Wendy, which I'm sure Wendy can talk more about.
Yes, indeed. You've really answered it well, Kate. And I think the conversation has started from different quarters, including our education department, training for our students, most especially, because it's good to start right from the foundation, So yes, a conversation around decolonization of the curriculum has started, and also even the equipment that are being used, in those during the training, and universities needs to look like different communities. And a very good example is about the ABGA score. The ABGA scoring, and there's a lot of research being done into that, because again, for many years, for decades, I've trained as a midwife for over 2 decades now, and the way we're trained was all babies were born pink, but is that true for Black and Asian babies? So those conversations have started, which is the direct way to go.
Fantastic, thank you. We have another question actually just come through from Shiona Brown. I am a midwifery lecturer in Scotland. Our issue is lack of representation from wider ethnic groups. We have very few Black and brown student midwives. Do you have hints and tips as to how we can attract more students that might actually represent the women and families we care for?
Do you want me to come into that, Kate?
Yeah.
Indeed, you know, I think part of our equity and equality guidance is to, you know, advocate, and even our chief people's officers also, you know, alluded to this, that your workforce should reflect your community. And how does that work in terms of recruitment? So you really need to go out to different communities and make and promote midwifery, basically, you know, go to schools. And these are the things that we are doing in England. You know, we have midwifery ambassadors actually stepping into that space in terms of perception of midwifery. And this is one of the work that the chief midwifery officer is leading on as well. You know, going to the university, to primary schools, secondary schools, and tell them about, you know, midwifery. And I've been on one of those calls, speaking to hundreds of, you know, primary and secondary school. So lovely, the best call I've ever been on, you know, telling them how, you know, I trained as a midwife, what I do as a midwife, very exciting. So those are the practical things you can start doing. And obviously in the media as well, you know, and also get those little ones that we have to showcase them and represent them, for them to be on posters. If you have Black midwives, male midwives, you know, always put them out there, you know, to talk about what midwifery looks like.
Thank you. We don't have any more questions at the moment, but if you'd both be happy, I mean, if there are any follow-up questions, I will share them both with you and try and come back to the people who asked any questions. But unless there's anything else that's going to come through, I'd just like to say a huge thank you both to Kate and to Wendy for your really engaging and interesting talks today. Thank you very much. We have recorded this and we will share it. If there is, as I say, that there's more webinars coming up, so please do sign up, and that's it from us today. So thank you both and have a lovely afternoon.
Thank you.
Thank you.
Bye-bye.
Bye-bye.